Okay, let's unpack this. Because we usually think of medical guidelines as these dry, dusty rule books. But what we're looking at today is actually a blueprint for treating the whole person, not just the disease.
Yeah, exactly. I mean, it's a total paradigm shift in how we approach this.
Right. So in the United States, if you see a woman under 40 in a breast cancer clinic, she's a statistical anomaly. This specific demographic makes up just 4% of all cases here.
Right, 4%. It's tiny.
It is. But then if you walk into a waiting room in a low or middle income country, the picture completely flips. Over half the patients in that room, 55%, actually will be premenopausal.
It is a staggering disparity, and it forces us to completely reframe how we view the disease globally.
Because it's a completely different landscape.
Exactly. You have this intersection of younger overall population demographics in those regions, differing environmental risk factors, and severely limited healthcare infrastructure for early detection. The disease just presents entirely differently based on where you happen to live.
And that demographic reality is exactly why we are doing this deep dive into the ESO-ISMO Fifth International Consensus Guidelines for Breast Cancer in Young Women, or BCY5 for short.
Which is a comprehensive 2022 medical document that basically shows how global science is rewriting the rules of oncology.
Yeah, and for a listener who's maybe prepping for a medical discussion or supporting a loved one or just fascinated by how complex systems solve highly nuanced problems, this is basically a masterclass in personalized medicine, because for a long time the approach was basically to just hit the tumor as hard as biologically possible, right?
Hit it hard and, hope the patient survive the crossfire.
Exactly. But these guidelines show a radical pivot. We are abandoning the one-size-fits-all approach to balance the aggressive biology of the disease with the preservation of the patient's entire lifespan.
And we really have to look closer at that biology, because even if you strip away geography, a tumor in a 30-year-old is operating under completely different rules than a tumor in a 60-year-old.
Because of the aggressive phenotypes?
Right. The guidelines note a significantly higher proportion of aggressive phenotypes in younger women. And the data shows that even when young women develop what are generally considered, less aggressive subtypes.
Like the luminal A one?
Exactly. Luminal A-like tumors, which are hormone receptor positive and tend to grow a bit slower. Even then, their clinical outcomes are still worse than older women with the exact same tumor type.
But wait, why is that? If the tumor itself is biologically the same subtype, why does the age of the host alter the outcome so drastically?
Because the environment surrounding the tumor is completely different. I mean, a premenopausal body is flooded with estrogen and progesterone.
Oh, right.
So it creates this highly active hormonal landscape that can inadvertently fuel tumor growth. And then you have to add the behavioral factors of treatment on top of that.
Like taking the medication.
Yeah. We frequently ask young women to take hormone-suppressing therapies for, 5 to 10 years. And the side effects, which basically force a younger body into sudden severe menopause, they're so intense that medication adherence rates drop significantly.
Wow, so the biological treatment is fighting a much steeper uphill battle from day one.
It really is.
And then you layer the socioeconomic reality on top of that biology, which the sources highlight through this massive Norwegian study. They tracked over 7,000 premenopausal women.
And Norway has universal health care.
Right. Meaning everyone theoretically gets the exact same access to the same hospitals, the same medications. Yet, over time, the study revealed that the 5-year survival rate steadily improved for patients with high socioeconomic status.
But it flatlined entirely for low socioeconomic status patients.
Which is just so sad. It's like assuming a fire alarm in a mansion and a fire alarm in a crowded apartment building will result in the exact same fire department response.
Yeah.
The data shows the system sadly doesn't work that way.
It clearly illustrates that having physical access to medicine isn't the same as having the capacity to actually survive the treatment process.
Yeah.
Lower socioeconomic status mechanically translates to poorer outcomes because it correlates with a cascade of other vulnerabilities. Higher baseline chronic stress, lower nutritional baselines.
A lack of workplace flexibility.
Exactly. If you cannot afford to take time off for debilitating treatments, or you lack the resources to navigate the complex insurance and scheduling logistics, even a universal healthcare system fails to protect you.
It really shows how a treatment plan cannot exist in a vacuum. But let me push back on something here. If the biology of the tumor in a 30-year-old is inherently more aggressive, shouldn't the default medical instinct be to just hit it with the hardest, most toxic treatments available right away? Like, just blast the system to eradicate the cancer at all costs?
That's the instinct, sure. But that maximum toxicity approach causes irreversible, massive collateral damage to the patient's heart, their bones, their reproductive system.
No.
Yeah, and the DCY5 guidelines are forcefully pushing back against that instinct. They argue that to increase survival without destroying the patient's future, you don't need maximum force, you need maximum precision.
Which means doctors need a much better map of the threat before anyone picks up a scalpel or an IV bag.
Precisely.
So let's start with physical imaging, because we know routine 2D mammograms struggle with young women. Premenopausal breast tissue is just extremely dense.
Very dense. And dense breast tissue contains higher amounts of glandular and connective tissue, which appears white on an X-ray.
And tumors also appear white.
Right. So traditional mammogram often fails to distinguish the anomaly from the background structure. It just blends in. That's why the guidelines mandate a shift to digital breast tomosynthesis, or DBT.
Because DBT doesn't just take a flat, overlapping picture. It captures like 1 millimeter 3D slices of the breast.
Right. Exactly. By viewing the tissue in these ultra-thin slices, radiologists can look past those overlapping structures that create the dense white shadows. It exposes tumors that a standard 2D scan would just completely obscure.
And when they need even more detail, the guidelines are now introducing abbreviated MRI, or ABMRI.
Yes, which is a game changer.
Because a full breast MRI is highly sensitive, sure, but it takes nearly an hour, it requires contrast dye, and it costs a fortune. So how does ABMRI solve that access issue?
Well, instead of mapping every single structural detail of the breast tissue over 45 minutes, ABMRI is a rapid 10-minute scan. It's specifically looking for functional anomalies.
Okay, functional anomalies, like what?
Tumors build these massive chaotic networks of blood vessels to feed themselves. So ABMRI focuses purely on catching those hypervascular traffic jams as the contrast dye moves through.
Oh, I love that. ABMRI sounds like reading the cliff notes of a dense, complicated book. You get the critical plot points in a fraction of the time and cost.
That's a great way to put it. It highlights the danger instantly, without the overwhelming financial cost or time burden.
But even with 3D slices and rapid MRIs, I mean, physical imaging is inherently reactive. You are looking for a fire that has already started.
Right, you're looking at the smoke.
Yeah. So to truly customize a patient's survival plan, the guidelines mandate we look for the kindling before the match is even struck, which requires a pivot from physical imaging to genetic mapping.
A huge pivot. They state unequivocally that every single young woman diagnosed with breast cancer must be offered genetic counseling.
Every single one. But wait, does testing every single young patient for genetic mutations risk opening a Pandora's box of anxiety and information overload for someone who's, already dealing with cancer diagnosis?
I get why you'd ask that. But this genetic information isn't about inducing panic. It's a non-negotiable standard, because finding a pathogenic variant like an inherited genetic mutation, it fundamentally changes the surgical and systemic approach from day one. It's the exact architectural blueprint needed to calibrate treatments and avoid the sledgehammer approach.
And the stakes of finding those mutations are incredibly high. The sources mention the TP53 mutation, which causes Li-Fraumeni syndrome.
Yes.
Imagine being a patient, absorbing the trauma of a cancer diagnosis, and then learning you have this mutation, which means the very radiation therapy meant to cure your breast cancer will likely trigger entirely new secondary cancers in your body.
It is a terrifying catch-22 for the patient. They have to avoid radiation entirely and rely on contrast-free whole-body MRIs for future screening. The psychological weight of that knowledge is immense.
I can't even imagine.
But flying blind is far worse. If a surgeon doesn't know about that TP53 mutation and proceeds with standard radiation protocols, they are actively, albeit unknowingly, harming the patient.
Wow. Yeah, that makes sense.
Genetic data provides the blueprint needed to avoid those catastrophic clinical errors while making sure the patient isn't undertreated just out of caution.
Which leads us to one of the most crucial distinctions in modern oncology, something we need to clearly separate for you listening at home: genetics versus genomics.
Yes, the terminology is often conflated, but they represent entirely different maps.
Okay, break that down for us.
So, genetics, like a BRCA or TP53 mutation, that tells us what the patient inherited from their parents. It is the baseline code of the host.
Right.
Genomics, on the other hand, tells us what the tumor itself has mutated into. When we run a genomic assay, we are testing the enemy's DNA, not just the victim's.
Testing the enemy's DNA. And that is how doctors determine if they can safely spare a patient from chemotherapy.
Exactly.
The guidelines lean heavily on genomic assays, specifically highlighting the ARC-Sponder and MUNDACT clinical trials.
Right, those trials analyze the genomic signature of estrogen receptor-positive tumors to identify which ones are actively driven by pathways that chemotherapy can actually interrupt.
Because chemo isn't just a magic bullet.
No, chemotherapy is essentially a systemic poison that targets rapidly dividing cells. If the tumor's genomic signature reveals it is slow-growing and biologically immune to chemo, administering it offers absolutely zero survival benefit.
While still subjecting the patient to brutal, long-lasting toxicity.
Exactly.
But the guidelines also point out a glaring blind spot in these massive trials. Like in ARC-Sponder, women under 40 made up less than 3% of the participants.
It's a very small subset.
So wait, if young women are vastly underrepresented in these big genomic trials like ARC-Sponder, how can doctors confidently look at a 32-year-old and say the data proves she can skip chemotherapy?
It requires a highly calibrated balancing act. Doctors do not look at the genomic score in isolation. They extrapolate this data carefully by weighing it against the clinical features.
Like what kind of features?
The size of the tumor, how many lymph nodes are involved, the cellular grade. If the clinical risk is moderate, but the genomic score indicates an absolute lack of chemosensitivity, they can confidently omit it. Because skipping unnecessary chemo isn't just about avoiding side effects today. It is vital for preserving the patient's entire future, specifically regarding family planning and ovarian function.
Right. But omitting chemo does not mean doing nothing. For these estrogen receptor-positive cancers, the alternative is aggressive endocrine therapy.
Yes.
The guidelines reference the SOFT and TEX-T trials, which completely changed the standard of care for high-risk young women.
Those trials proved the absolute necessity of ovarian function suppression, or OFS.
Which means shutting down the ovaries.
Yeah. Exactly. In premenopausal women, the ovaries are the primary factories for estrogen. For high-risk, hormone-driven cancers, simply taking a pill to block estrogen receptors isn't enough. OFS uses medication to completely shut down the ovaries, cutting off the fuel supply at the source.
And then they combine that with aromatase inhibitors. How do those work in tandem with shutting down the ovaries?
Well, even with the ovary shut down, fat and muscle tissue still produce trace amounts of estrogen through an enzyme called aromatase. So aromatase inhibitors wipe out that remaining enzyme activity. You are effectively starving the tumor of its primary growth signal.
But the cost of that starvation tactic is inducing a sudden, severe medical menopause in a 30-year-old.
It's incredibly harsh.
Yeah, leading to rapid bone density loss, severe hot flashes, sexual dysfunction. It's a highly effective strategy, but it demands intense symptom management to keep patients from abandoning the treatment altogether.
And we see a similar precision strategy with the Olympiade trial, which looked at patients who inherited BRCA1 or BRCA2 mutations.
Right. The trial showed that giving these patients a targeted drug called olaparib for a year significantly improves survival. And olaparib is a PRP inhibitor.
Correct.
How exactly does a PRP inhibitor isolate and kill the cancer cells?
So think of PRP as essentially a protein repair kit for cells. When a cell's DNA is damaged, PRP rushes in to fix the break.
Okay.
Now, patients with BRCA mutations already have a crippled primary DNA repair system in their cells. When their cells turn cancerous, they rely almost entirely on that PRP backup repair kit to survive and multiply.
Oh, wow.
Yeah, so olaparib specifically destroys the backup kit. Without it, the cancer cells sustain too much DNA damage to replicate, and they die.
That's amazing.
It's an elegant mechanism called synthetic lethality. You target the tumor-specific vulnerability while sparing the healthy cells that still have their primary repair systems intact.
But even with these highly targeted therapies, the treatments still take a massive physical toll, which brings us to the guidelines' strict focus on preserving the patient's future.
A huge priority.
They mandate that fertility preservation must be discussed before any systemic treatment begins.
Yes, because the moment chemotherapy enters the bloodstream, the viability of a patient's eggs plummets. Cryopreservation freezing eggs or embryos must happen prior to that toxic exposure.
It's like pausing a video game to secure your save file before walking into a massive boss fight. You have to lock in those fertility options before the chemo starts.
I love that analogy. You definitely need that save file.
And there's also a secondary biological shield doctors can deploy during the chemo itself. They administer monthly GnRH agonist injections. What is the mechanism there? How does an injection protect the ovaries from chemo?
Well, a GnRH agonist essentially overstimulates the pituitary gland until it temporarily exhausts itself.
Oh, it just tires it out.
Yeah, it shuts down the hormonal signals that tell the ovaries to function. So it puts the ovaries into a deep, dormant sleep, reducing the blood flow to them.
Okay, I see.
By keeping the follicles inactive, it helps hide the ovarian reserve from the toxic wash of chemotherapy circulating in the blood.
Though the sources emphasize this is just a shield, it does not replace cryopreservation. It's more like a belt and suspenders approach to protecting their future options.
Precisely. You want multiple overlapping layers of protection whenever possible.
Speaking of the future, the guidelines completely dismantle a massive, decades-old medical myth.
This is a big one.
For generations, survivors with estrogen-driven breast cancer were terrified that getting pregnant would cause a recurrence. The logic seemed sound at the time, right? Estrogen feeds the cancer. Pregnancy produces a massive surge of estrogen. Therefore, pregnancy is a death sentence.
It was a deeply entrenched fear based entirely on biological theory rather than clinical data. But long-term, large-scale studies finally proved that theory wrong.
Thank goodness.
The data emphatically shows that pregnancy after breast cancer does not increase the risk of recurrence, not even for hormone receptor-positive patients.
So the current protocol advises these patients to complete 18 to 24 months of their endocrine therapy, securely pause their medication to attempt pregnancy and breastfeed, and then resume the medication to finish their 5 to 10-year course.
It totally transforms family planning from a fearful unknown into a managed, intentional clinical timeline.
But preserving a life isn't just about biology and family planning. The guidelines highlight Project 528, which is a global needs assessment focused on the psychosocial toxicities of a cancer diagnosis. And this circles perfectly back to that socioeconomic data from Norway we talked about earlier.
Yes, Project 528 maps out how financial and social strain directly degrade physical survival.
Because when a young adult is hit with cancer, they are often in the most vulnerable stage of wealth building and career establishment. Right?
Exactly. They face immediate job insecurity, crushing insurance deductibles, and severe strain on young marriages. Psychosocial toxicity isn't just about feeling anxious or sad. It's a mechanical breakdown of care.
Right. If a patient is overwhelmed by medical debt, they skip follow-up appointments.
Or if they lose their insurance, they ration their endocrine therapy. Their survival odds drop off a cliff, not because the drugs fail, but because the infrastructure of their life collapsed.
Which proves you cannot treat the tumor without treating the environment it lives in. Yet, for all this precision, the guidelines admit there are environments the medical community still fundamentally doesn't understand.
There are glaring blind spots.
Specifically overlooked demographics. Male breast cancer, for instance, it makes up about 1% of all cases, and men under 40 are a fraction of that fraction.
And the psychological isolation for those men is staggering. They are navigating a disease universally coded as female, with literature, waiting rooms, and support systems that completely exclude them.
Yeah.
And medically, they are often treated based on data extrapolated from female trials, which largely ignores the unique hormonal landscape of the male body.
And that data gap widens into a complete canyon when discussing transgender and non-binary individuals.
It really does.
The guidelines state clearly that there is a near-total lack of data regarding breast cancer in individuals receiving gender-affirming hormone therapy.
If precision oncology relies on mapping the exact hormonal and biological environment to calibrate treatment, ignoring the distinct hormonal realities of transgender and non-binary patients means we are treating them with a blindfold on.
Wow.
We simply do not know how exogenous testosterone or estrogen regimens interact with tumor biology or how they affect the efficacy of systemic therapies.
So the guidelines issue an urgent call for cancer registries to start tracking transgender and non-binary identities, which makes sense. But let me raise a practical pushback here. With such a tiny percentage of cases in these specific demographics, is it practically feasible for the medical community to design massive clinical trials just for them? Or are we permanently stuck trying to extrapolate from cisgender female data?
Recognizing what we don't know is the critical first step. You're right, you cannot recruit 10,000 patients for a trial if only a few hundred exist in the system.
Right.
But by mandating that global registries systematically capture this demographic data, researchers can pool real-world outcomes over time. They can slowly build the statistical power needed to provide evidence-based, tailored care for these marginalized groups.
It's about building the map one data point at a time. And looking at the entirety of the BCY5 guidelines, that is really the core narrative here. We are witnessing the end of the brute force era of oncology for young women.
Absolutely.
It is no longer acceptable to just eradicate the disease and leave the patient to pick up the pieces of their broken biology. Every single decision, from 1 mm 3D imaging to sequencing the tumor's genomics, to triggering synthetic lethality with PRP inhibitors, to intentionally pausing therapies for pregnancy, is a calculated balance. Doctors are constantly weighing how to stop the cancer today while aggressively preserving the patient's entire tomorrow.
Medicine is finally recognizing that survival isn't just maintaining a pulse. It is ensuring the quality, functionality, and potential of the decades that follow the cure.
Beautifully said. But I want to leave you, the listener, with a final thought to mull over. We talked heavily about how genetic mapping is changing treatment today. Well, the sources briefly touch on something called polygenic risk score models.
Yes, those are fascinating.
Currently, these are experimental models that evaluate dozens, sometimes hundreds, of minute genetic and lifestyle markers to estimate an individual's precise breast cancer risk. The guidelines state they aren't quite ready for standard clinical practice yet. But imagine a near future, maybe a decade from now, where a simple cheek swab at birth provides a hyper-personalized, highly accurate roadmap of your lifetime cancer risk.
It would completely erase the concept of being at average risk entirely.
Exactly. If you knew from day one exactly what your personal biological minefield looked like, how would you and how would society at large handle that profound level of foresight?